Welcome to the Aig-Imoukhuede Foundation podcast, where we explore how smart investments in leadership and systems can transform public service across Africa. My name is Ofovwe Aig-Imoukhuede, and I'm the Executive Vice Chair of the Aig-Imoukhuede Foundation. Today, we will be taking a journey to the very heart of Nigeria's health system, the primary healthcare frontlines. Our focus is on a vital yet often overlooked force in healthcare, community health workers and the future of care. In a country where nearly half of our population lives in rural areas, these workers are more than just a link. They are often the only lifeline to healthcare for millions. But here's the difficult truth. Despite carrying this immense responsibility, they themselves often face a system that holds them back from reaching their full potential. So the question we are asking today is a critical one. How can Nigeria truly empower these frontline heroes? How do we make sure they have what they need to deliver quality, equitable healthcare for everyone? To help us unpack this, I am truly delighted to be joined by an important voice for this cause, Dr. Nonye Egekwu, a powerful advocate for improved healthcare delivery at the grassroots, with a deep experience working across tiers of Nigeria's healthcare leadership to strengthen our systems and ultimately save lives. Dr. Nonye, welcome to the podcast. Dr. Nonye Egekwu is a healthcare quality improvement consultant and technical advisor to government institutions with extensive experience in designing and leading large-scale health system interventions. Over the years, she has contributed significantly to strengthening programs across diverse healthcare market archetypes, with a proven track record of driving measurable improvements in health system performance. Her work reflects a deep commitment to expanding access to quality healthcare across the primary, secondary, and tertiary tiers of Nigeria's healthcare governance landscape. Dr. Nonye is also a friend of the house and a former director here at the Foundation, where she led the strategies and operations of our health philanthropy unit. Her insights were instrumental since the department's inception, and it's a pleasure to have her back with us for this conversation. Dr. Nonye has designed and led several high-value donor-funded quality improvement initiatives with substantial financial commitments tailored to various health system contexts in Nigeria. In her current role as Senior Advisor Quality and Learning on the National Health Insurance Authority Comprehensive Emergency Obstetric and Neonatal Care Program, Dr. Nonye leads the design and implementation of quality improvement strategies for more than 200 secondary and tertiary hospitals across all states in Nigeria. She's an active member of the International Society for Quality in Healthcare and serves as a faculty member in Healthcare Quality Improvement at the Healthcare Leadership Academy, Africa. She holds a Bachelor of Medicine, Bachelor of Surgery from the University of Nigeria, Nsukka, and a Master of Science in Global Health and Development from University College London. Dr. Nonye, thank you for joining us.
Thank you so much, Ofovwe. It's wonderful to be here. I'm really excited.
Great, thank you. So let's just get right into it. I want to start with a story that really stuck with me. I recently read about a young mother in a remote part of Niger State who, after giving birth, developed a dangerously high fever. The nearest clinic was hours away, a journey that just wasn't possible in that instance. But in her village, there was a woman named Aisha. Now, Aisha stepped in, conducted a basic health assessment, administered a critical first dose of treatment, and arranged for a referral. In that moment, she potentially saved a life. Dr. Nonye, that story makes me wonder, for our listeners who might not know, who is the Aisha in their own community? And when we say community health worker, what does that person actually do day to day? And why is that single role vital to the health of an entire community?
Thank you so much. Well, I think that's a great question. Aisha is your typical community health worker. most likely a community health extension worker. She is a trained healthcare worker providing certain basic healthcare services, particularly in rural communities and or underserved communities, especially in areas where access to provision of care from the higher cadres of healthcare workers are absent. For example, the doctors, nurses, midwives, and so on. So that's who Aisha is. She's a typical community healthcare worker, and you're likely to run into Aisha in rural communities or underserved communities. Just to add, she's most likely either a community health extension worker or a JCHU, a junior community health extension worker, typically. So I will say that, in addition, her role, because she is part and parcel of she's part of the entire healthcare system of our dear country. And when you want to look at it, when it comes to cadres, she is at one of the lower rungs of the ladder in terms of expertise, clinical expertise. But she plays a huge role in ensuring that she can link. So she's that bridge. The community health workers are that bridge between the rural communities and the healthcare system. And for many communities, they are the face of the healthcare system, because before, for communities where you have to travel hours to get to a proper hospital, Aisha is likely to be the first person or your first point of care, to administer some kind of first aid, some kind of basic care before you even get to a hospital. So that's really where Aisha functions. She's linking the primary healthcare centers to the communities. That's actually her typical and ideal role. Yeah.
Thank you so much. Now, you talked about community health extension worker, and you mentioned something called J2. For those who are not really conversant with what sort of training or qualifications people at that level are, can you please just break that down a little bit? Thank you.
Okay, so the ideal thing in our Nigerian framework is that the community health extension worker should be placed within the community. She or he is trained to administer certain basic life-saving interventions in these communities, and when patients or community beneficiaries need a link to the health system, like the primary healthcare center, for example, they are that link. So they will ensure that they have done the needful within the communities, whether it's the markets, the churches, the mosques, the traditional, within all of our typical traditional levers, community levers. They will do the needful, and then they can link you to the PHC where you need to. Sometimes they are involved, many times they're involved in vaccinations. They are involved in things like, rapid testing for malaria, administration of, anti-malarials, among others. So that's typically it. I know we can go, and I'm sure as we continue, we'll have conversations around, is that what's happening now? Because this is the ideal, this is what's in the framework, but is that where we are at the moment? But I'm sure we'll unpack that as we go ahead.
Yes, that leads me right to my next question. So, in the framework, the community health worker is embedded within the community and is supposed to cover a specific area, right? So typically, what are the sort of numbers that one community health extension worker is supposed to cover in terms of demographics of people? And what is actually the case on the ground?
I see. So speaking of ratios, I think these have changed over the years. And this is why, Ibisi, there's been a lot of modifications. There's been something called the task shifting policy. So I'm coming back to the exact question on numbers, but I just want to put this out there. It's pretty difficult because right now, in many underserved communities in Nigeria, community health extension workers are now in the primary healthcare centers, and they are attending to patients. They are seeing patients, seeing mothers, seeing children. And this comes under our task shifting policy. And this is because there is definitely a paucity of doctors, of nurses, of midwives. We already know that. So they're beginning to be called in to fill the gap. And this has been happening for many years. Not just the community health extension workers, but also the JHUs, so the junior community health extension workers as well, are now in the PHCs. So it's pretty difficult at the moment to give exact ratios of one community health worker to to the communities where they serve at the moment, because a lot of them are now sitting in our PHCs. And I guess whether that's good or bad, it's something that we can unpack as we go ahead. But there definitely are policies to guide and couch these modifications that have happened over the years.
Thank you for that clarification. So, originally, community health workers, community health extension workers, and the junior workers were supposed to be based in the communities themselves. But because of paucity of human resources, they are now in the PHCs. So, for many, many Nigerians, over half of who live in rural areas, these community workers are the system. They're not an addition to the system. They are the primary contact in terms of healthcare. So you have been at the forefront of shaping public policy for years. From your front row seat, what makes community health workers indispensable to Nigeria's goal of universal health coverage? You've already hinted at it, that, they are the ones who are at the primary health centers and who actually deal with people who come into those health centers on a daily basis. But maybe bring it a little bit to life for us. Share a story from a years of on the ground that has stayed with you about how indispensable these workers are to health coverage.
Thank you so much, AVC. I will definitely share a personal story. Some years ago, when I was leading a project on non-communicable diseases, diabetes, hypertension, and the aim was to improve access to care and even the availability of data within the country for NCDs, non-communicable diseases. We had some of those meetings and trainings for healthcare workers at the primary healthcare centers. And this was going on at the time in two states, I meant to say, one in the north and one in the south. I recall I was one of the facilitators for the training, as well as leading the project in one of the states at the time. Guess what? We came into the hall and for the initial training, and when we looked through the attendance list, we saw quite a number of community health extension workers on the attendance list who were coming as staff from the primary healthcare centers. And when we had these conversations with them and with, the boards within the state, so the state primary healthcare development agencies and boards, it was clear that in certain underserved communities, they were the face of the healthcare system. They were the ones that the patients would see when they came into the PHCs. So you see, we can't even, to be honest, we can't even be talking about their indispensability, because they clearly are a huge part of the Nigerian healthcare system. I recall this attendance list I'm talking about in one of the states in the country, like I mentioned. It wasn't, I'm talking like well over 10, 15, 20 primary healthcare centers being represented by community health extension workers and junior community health extension workers. And they were not sent there by, the officers in charge, OICs, like they say in Nigeria. They were the OICs in these PHCs. That stayed with me for a while, because clearly this is a representation of what's happening across many states in our dear country, where community health extension workers are part of the primary healthcare system. And I'm sure as we go forward, we'll probably talk about other things as to how you can then frame the work that they do and all that. But this was something that stayed with me as I looked in that hall and I saw that these were women. A lot of them were women, but there were men as well, who were attending to patients every single day. So these ones had even kind of morphed, from their typical roles in the community to being employed in the primary healthcare centers and doing the work front and center there.
Wow, thank you, Dr. Nonye. So we've all seen the headlines. We know that a lot of doctors and nurses are leaving for better opportunities abroad, which is why there is such a huge gap that community healthcare workers are now filling. But, what is it that they experience when they're doing this critical life-saving work? I understand that many of them earn less than 50,000 a month. They work without transport, without even the most basic supplies like gloves that they need to do their job safely. So, since they are now an integral part of the primary healthcare system, how do we really frame them, and how do we ensure that they have everything they actually need to execute their roles properly? Because if they have moved from being sort of like a supplementary part of the system to actually an integral part of the system together, what holds the primary healthcare system together in many parts of the country, isn't it important for policy to shift to ensure that they have everything that they need to support them to carry out this work? Because just thinking about saving lives on a daily basis, yet not having the tools that you need, not being properly incentivized, how do we expect them to really do their jobs properly?
Thank you so much, EBC. I mean, I'm just smiling because this is a really nuanced question. And I think that we can talk about this same way you can talk about a lot of other human resources for health challenges within the healthcare system. I think that, and I mean, there are many ways to think through this. I think that clearly, I mean, Nigeria is well over 200 million people, and we know that we have a paucity of doctors to nurses. The ratios are alarming, and as a result, the NPHCDA, I mean, over the years, like I mentioned, there's been a lot happening with policy. The task shifting policy, for example, which is already in place across the states in Nigeria, is one of those frameworks that help the community health extension worker understand their role, their job description, understand where their boundaries are, understand where they need to refer as well, understand what they need to do before they refer, understand things around the data and all of that. So clearly, the problem is not the policies. We have policies on ground, and there's been a whole lot. I know even last year there were conversations where I think the NPHCDA executive director, had also shared most of these, policies and mentioned and really discussed all the beautiful things that are happening within the system. So clearly, there's a lot on ground as per frameworks, policies, policy intent, and all of that. I think the challenge, like you have already mentioned, is not far-fetched. There definitely are many things with funding. There are many challenges with institutionalizing the community health extension worker, mainstreaming their role. There are also challenges around frequent performance reviews. So, which again, like I mentioned, this is not typical to the community health extension worker. You will see this across our health system in many fronts. But these are some of the challenges that I would say will definitely form barriers as to why the community health extension worker will not do their job optimally. Let me zone in on one. So one of them is, again, mainstreaming the community health extension worker, for example. And you might as well group them alongside other primary health care workers, because they work together. In some places they are the OICs, in some places they are supporting the OICs, but a lot of them are in our PHCs. We need to begin to think of, and I know, again, like I said, these things are, we have the policies, we have the framework. Sometimes implementation is a huge challenge. But how do we then begin to move from having beautiful frameworks on paper to actual implementation and a course correcting? So within a year, for example, have there been times when we want to go in and say, this is what we were supposed to do as per job description? Have we done that? Did we exceed our boundaries? Have we done, what we were supposed to do, what we were paid to do, what we were employed to do? And then what are the challenges that you're facing? I see, and this is across my work, across the states, across the years, I see that this is where we have a huge gap. Because if we're doing that, which is there is some kind of performance review, there is some kind of review, and the data that is being churned out is being reviewed almost in real time and used to make decisions that feed back to the community health extension worker where she or he is. This will help everybody not just be on their toes, but really appreciate the job that they do, give it their best, understanding that the job doesn't end with you, but that that there are indirect consequences of my work that trickle all the way up, all the way down, and across. So I think that frequent review, that frequent conversation, that's the word I was looking for, the frequent conversations, with the staff at these healthcare centers, particularly with the community health extension workers, needs to happen. And when we sit down to have those conversations, those meetings, those reviews of our frameworks, we need to be doing that with data at the center and on the table.
Thank you so much. That's so important, because even where there are policies, you talked about the fact there is a task shifting policy, but if you don't have data, if you don't have accountability, if you don't review and go back and engage and pivot, then everyone will be stuck where they are. And all the beautiful policies that have been written are of no use. So from your own experience on the ground, from your own experience in your role as technical advisor, what do you think are the concrete steps that actually need to be made to ensure that this data and accountability and all the performance management aspects that will actually lead to improved experiences for patients at the healthcare center? What is it that needs to be done to actually implement it? Is it just a lack of resources, a lack of funding, or a lack of understanding at higher levels of the steps that need to be taken to ensure that the policies are properly implemented?
I think this is really a great and thought-provoking question, EVC, because again, it's not one thing. It's not a magic bullet. There's no specific arrow that'll be shot and we'll get it right. But I know that it's a combination of many things, and one of them, which I like to start with, is leadership. There has to be political will across every tier of our healthcare leadership system. There just has to be. So when we talk about this, I'm not just talking about the presidency. So this isn't political will from Abuja. This is political will from the MPHCDA, the SPHCDA, down to the local governments, down to the communities, down, it has to trickle all the way down from federal to state. There has to be political will at every level. And when this is there, then we can begin to, because like I mentioned, we already have these policies. All we need is implementation. When there is political will, when there is somebody reviewing, when we're having these performance-based conversations, which should not be one-offs, it shouldn't happen when maybe a donor comes in and then there is some amount of money, and I can give so many examples, and as a result, we can run some of these performance-based reviews with our data for, say, a few quarters, and that's the end. Until we get another donor funding. We need strong political will that ensures that in every state, in every local government, and we already have the levers on ground. In every state, in every political local government, there is a structured approach. And again, I keep saying, if we go back to our policies, most of these things are already there. There's a structured approach to reviewing our performance and reviewing our data. I think it's excellent to mention that it's been in the news recently. I'm sure many of us have already seen it, that the Ministry of Health, Federal Ministry of Health, has mentioned clearly that, look, so and so amount of money in billions of naira have been disbursed directly to the primary healthcare centers. What this means is that power has moved, not just from the center, but it's now resident with your PHCs. And they sent out a red letter saying everybody should begin to hold the officers within their communities accountable, which is excellent if you ask me, because now we know that, okay, there's money available, and people are aware, so accountability will be something that will be coming up, particularly with the publication of that publicizing of the red letter. So I think that it's really important, if we have political will, down to our commissioners of health, all of our health officers, down, and I keep saying down because when you get into the healthcare system, there are so many levers. But if we have political will at every single level, and everybody knows that periodically, so it's already structured, it's not a reactive thing. We already know that probably at the end of Q1, there's going to be a meeting, we're going to have conversations. And even before the end of that Q1, for example, within the system, there's already data and someone is course correcting in real time. I have seen this when we have tried to model this and do this on certain projects, which we have done over the years. I think one of the longest was well over 5 years. And I saw very clearly that when everyone began to catch up on the structured approach of performance reviews over time, indices improved, healthcare indices improved, satisfaction even by the healthcare workers improved, because suddenly people understood that, hey, my data is also my power. I'm putting out data and it's being used to improve decision making in healthcare. So everybody sat up, everybody owned this. So I think that's really it. Leadership is at the center and the buck rests on the leaders' table. So that political will that we're seeing even from the center now with the current minister and all of the many things happening within the healthcare system should trickle down. It should be there down to the local government level where everybody is beginning to say, hey, let's see what's happening within our healthcare system, within our primary healthcare centers, and we need to begin to look at our structured approach. What was our plan for the year? Have we met this year? Have we discussed our data? What are our indices saying? How many mothers came in? Do you see? How many people were treated for malaria? How many mothers did we lose our mothers? How many died? Why? Those conversations need to be frequent, if we're ever going to move forward.
Amazing. Thank you for that. So much needs to be done to support these very essential frontline workers, but it seems that there are so many levers that need to be pulled simultaneously to actually shift us from where we are to where we need to be. So let's just take into account everything that you have said and all the different issues, all the different factors that are at play. If you were in the room advising these leaders on 2 or 3 changes to make that will actually have the biggest impact on community health workers on the ground and their ability to deliver services to their patients, what would these be?
I like this question, EVC. I really do, because I just wish that once we see the changes, we see them immediately. But yes, there are certain things that I think that really tug at my heartstrings, and I would say that if we do these, or rather, if I'm sitting in that room, these are the things that I would say. The first one is the fact that there needs to be, again, I keep saying, some structured approach. That's the first one, to reviewing the performance of our community health extension workers. And with this approach, this periodic structured approach, again, we say in quality, no shame, no blame. The aim is not to witch hunt, but really to understand what we're doing and if we're achieving the aims for which we have set. So we need to have that. And with that then comes the next thing. We need to equip the community health extension workers with the right tools to do their work. Again, we have the policies. I have been part of contributing to one of the task shifting policies for some of our states in the past. And so I have seen the policies. They're quite comprehensive. They cover quite a whole lot. So the first one is we're reviewing this periodically. And within this bucket of reviewing it, we're ensuring that the community health extension workers are equipped to do the work. Now, these kind of trainings will not happen as one-off. So this is not, I was trained in 2022. This is us having an entire structured approach that ensures that after a certain period of time, maybe 1 year, maybe 2 years, 24 months, we need to go back and see, looking at the map, that entire map of our trained healthcare workers, and look and then say, we trained 70% of these on that. And after 2 years, are the 70% still within the system, for example? Have there been updates to that training? Should there be refreshers for that training? Have some of them exited the system? If they have, what's the percentage available? Maybe 50. So are we replenishing it? Do you see? So there needs to be that. It's almost like looking at the CCTV in a supermarket. You don't leave it because you have a CCTV and then you come back to it after a month or 2 months when there's been a robbery. This is something that we're doing consistently. And because of that, we're filling in the gaps, whether it's technical gaps or human resource gaps. And, we're doing that. So that's the first thing I'll say, a periodic review of everything. Within that, we're equipping the healthcare workers periodically to do the work. The second one I'll say is data is gold. We need to mainstream our data, whether it's coming from the communities or from the primary healthcare centers. We need to be able to mainstream our data. Are we looking at it? And when I say we, I'm not just talking about, those who are maybe at the highest level, maybe at the Federal Ministry of Health or the MPHCD, even down to the community level. Do we have the community health extension workers, their officers in charge, the local government officials, the people who are working very closely with our PHCs? Are they reviewing the data? Do we have an idea at that point? And this is what I would tell, them in that room. There needs to be that structure. There needs to be that framework. And if we already have it, then there needs to be a performance review on if we are doing this. So the second one really is data is gold. Data must sit at the center of every single meeting we're having on community health extension workers, from the local government up all the way to the federal. And then the last one is sustained financing. Again, like I mentioned, I like the idea. I like what has been happening for a while, which is now primary healthcare centers have more autonomy with their monies, and money is coming to them directly. They submit budgets and this is approved and they are paid. And so they have more flexibility with working to improve, the service that they provide to their patients. with that, we need to ensure that this is sustained. Right now, this is coming through the Basic Healthcare Provision Fund, and it's been like that for a couple of years. So I'm not saying this is something we should do. I'm saying this is something that we should sustain. There should always, within our budget, be levers where community health extension workers and the work that they do is consistently funded. We can always, there are many layers to this where we can now talk about, how much are they getting, whether this, meets up minimum wage and the rest of them. But I think the first thing is, let's ensure that there is sustained funding, because financing is a huge bit of sustainability. So if you say really three things, the first one is performance reviews happening consistently, and within that bit is community health extension workers being equipped with the right tools, but within a structured approach where there are refreshers, there are updates, and it's consistent. The second one is data is gold. Everybody needs to be looking at the data coming out from the work that they are doing, including them as well. And then the third one is sustained financing for this group of healthcare workers if we're ever going to achieve universal health coverage in our dear country.
Amazing. From your ears to the people with the power to make these shifts, very necessary shifts. So let's imagine we are 10 years down the line and all of these recommendations that you have made are actually implemented. So what does success look like? How do you see community health workers shaping the future of care? And all of these recommendations that you have made, what sorts of shifts do you see happening, systemic changes happening to get us where we need to be?
Okay, so it's almost like we're looking forward now. What kind of shifts do we see happening? I think if we have done, let's assume that some of these things that we've discussed, so like the three things I mentioned, those things, we're beginning to see progress with all of that, and with that we're then working towards universal health coverage and the rest. I would say a few other things I think would need to shift us in the direction of success will be ensuring, let's just shift a little bit now from the community health extension worker to the patient or the community citizen that she's working with. It will be ensuring that there is some kind of financial buffer for these beneficiaries, the people who visit the primary healthcare centers or the people within the communities that the community health extension worker serves, that there is some kind of financial buffer, or at least healthcare, even if it's not completely free, it's affordable. When we speak of out-of-pocket payments, WHO generally prescribes 30 to 40%, for out-of-pocket payments at the most. But in Nigeria, we're currently on the average of about 70 or so. And with that, there's a lot that the government is currently doing. So the National Health Insurance Agency, and there's a whole lot. So with providing completely, so at no cost, providing care to mothers, indigent mothers who have obstetric emergencies, maternal emergencies, and they come to the secondary or tertiary hospitals at no cost. They'll be attended to. But if we take this down to the PHC, one of the shifts I'm seeing that it's important for us is we need to have financial buffer for the people that these community health extension workers serve, because it's not like when they run out of medicines at the PHCs or run out of whatever it is that they have with them. What then happens? The people cannot pay for care, and so everyone is looking at everybody. So there needs to be some kind of financial buffer. We need to keep working like we're already doing in the country as we see, to drop out-of-pocket payments as much as possible, even with, within the PHCs and that primary health level. And like I mentioned, I know that the NPHCD is also doing a whole lot with, the proposed and the CEmONC program, among many other things. So I would say that if we can crash our 70% out-of-pocket payments and it can come down to say 30 to 40, that would be huge. We will be heading in the right direction. I think the second one also is out-of-pocket payments, and okay, I think we've talked about data. I think with this, right, we'll be heading in the right direction to success. And really, what is success for us? I would say part of it will be that we're beginning to have improved indicators. So our healthcare indices, I think it's just a shame. In the past couple of years, Nigeria is topping the list of the worst places to have a baby, among so many other things. And trust me, when you get into the communities and at the primary level, the numbers are alarming. So again, when we begin to do all of these things that we've mentioned, and we begin to see shifts in our clinical indicators, things like reduction in women dying in these communities, improvement in newborns, newborn mortality is beginning to reduce, case fatality rates, for example, for complications, beginning to drop within these communities, then, we would say that we're beginning to move and shift the needle in the right direction, I must say.
Thank you so much, Dr. Nonye. So I have one final question for you, and this is for the listeners. You mentioned a few times about the fact that primary healthcare centers are being empowered now with funding, and that it was important to begin to hold them accountable to ensure that the funding was actually directed to the right places. So to the listener who wants to do this, what are the steps that they need to take to actually begin to hold people accountable? Who is it that needs to be targeted? Is it the local government chairman? Is it the ward development committees? What steps can the average person actually take to hold the primary healthcare centers accountable and ensure that the funding is used for the purpose to which it was sent?
So this is really similar to when we say we're holding political officers accountable. Everyone, if you are in these, everyone belongs to a community in Nigeria. And if you live in these communities, you should be able to walk into your local government office. You should be able to walk to your primary healthcare center and ask questions. You can ask questions like, what kind of services are provided here. You have a right to know if you live within the community. What kind of services are provided in your PHC, for example? Some people travel from one PHC to another or to a secondary facility because they just assume that vaccination doesn't occur here or nobody vaccinates babies here, for example. So the first thing is you being really aware of what services are provided within your community. You should know. And when you go in there, you should be able to ask questions. You should be able to find out for yourself. And you should be able to, so they would let you know if you ask them. So things like, is it dental? What exactly is it that's provided for you within your communities? And your ward development committees, we still have them, in the communities here. So people should also have an idea of who they are, because these people are part of the community. They are usually a mix of traditional rulers, people of good standing in the communities, but they are all part of the community. So you need to also find out who these people are. Who are your ward development committee members, for example? They are there. They are your everyday people. You want to know who they are. You want to begin to ask those kinds of questions. So I'll say it starts with awareness. It starts with, this is not a case of, to my tent, Israel, I'm doing what I'm doing. You want to be part of it. You want to find out. So walk into your PHC, find out what's happening. And if you're a member of the community, you walk into your PHC, you see maybe a leaking roof or something like that. You should be able to also own the problem. Ask, what's up? What's happening there? Is this a thing where we need to go to the local government to find out, is this a thing where we need to report? So I'm just saying that, especially with the red letter that was sent out, people need to go and understand exactly what services are provided for them within their communities. And when they do this, then they have an idea, and then they can also begin to hold their people accountable over time. For example, if you go and a community PHC says they deliver 24-hour care, and you get there at 4 p.m. and it's locked, you need to ask questions. What's happening? I've seen personal examples, if you see, where a community PHC would, I think that one was 12 noon or so, and it's locked. And when people, initially everybody just took it, oh, they close by 12 o'clock. Oh, they close by 12. But when we started to probe and say, why is that so? It's a full PHC. Why should it close by 12? And they said, oh, there are certain security challenges, so they have to close while the sun is still out and everybody has to run home. And that, you see, with those asking and those questions, people then began to pressure on the local government, put some pressure on the state government. The conversations traveled, and at some point they realized, oh, their fences were broken down. Security is a big problem for them. So let's do the needful. Okay, get their fences in place, put the barbed wires on top, have some kind of security man, do you see? And that now extends the time for which they can attend to patients. But if our communities just walk by and say, well, they close by 12 and that's what it is. No, you can't, because we won't have any results. So I would say it starts with awareness, and then with holding our officers' response accountable, by working in, asking questions and all of that. Tie those questions to what you're hearing in the news. And I mean, you'll begin to get answers going forward. So it's everybody's business. It's all of our business. That's what I'm saying.
Thank you. Thank you so much. Yes, I think as Nigerians, we have a tendency to point fingers and say, this is bad, it is this person's fault or that person's fault, and really not recognize the powerful role that we as citizens can play to ensure that our officers are held accountable. So for all the listeners out there, it's up to you now. You need to go and increase your level of awareness, as Dr. Nonye said, understand what services are supposed to be available to you in the community. And if this is not being met, then walk into your local government office or find out who your ward committee members are and engage with them. That is one step, at least a step that we can take as citizens while, we advocate for the politicians to actually take the steps, as Dr. Nonye outlined, to ensure that these wonderful policies that have been developed are actually implemented. So I think we can come to an end now. But what is clear from today's conversation is that for millions of Nigerians who live in rural areas, the community health extension workers are not just part of the healthcare system. As you heard Dr. Nonye said, there's been task shifting, and for many places, community health extension workers are the ones in charge of the primary healthcare centers and are the first point of contact for most people living in those rural communities. So it is very important that steps are taken to implement these policies that have already been developed to ensure that these community health workers are empowered to be able to deliver on this dream of universal healthcare coverage for everyone. So at the Aig-Imoukhuede Foundation, we believe that it is important to strengthen the healthcare systems to support these frontline heroes, from training programs to nationwide advocacy for their recognition, but most importantly, advocacy to ensure that the implementation of the policies that lead to their empowerment are actually successful. So if this conversation has resonated with you, we invite you to learn more about the subject by reading our technical article, Positioning Healthcare Workers as the Backbone of Primary Healthcare, which is available on our website. Dr. Nonye, thank you so much for your incredible wisdom, for unpacking this for us and showing us that this is a very nuanced conversation that needs to be had at many different levels. Empowering community healthcare workers is not as easy as it may sound, because we need to take a step back and look at the entirety of the healthcare system. And the issues that community healthcare workers face are the same issues that other healthcare workers face at secondary and tertiary levels. However, because community healthcare workers are the frontline heroes, they are the ones that actually deliver the care to, I would say, almost 50% of Nigerian citizens, it's important that we pay attention to them. So thank you so much, Dr. Nonye. It's been a pleasure having you, and look forward to continuing this conversation in the future.
Thank you so much, Ofovwe, and well done to the Aig-Imoukhuede Foundation, and for all the work we're doing with the primary healthcare centers and the primary healthcare system. Well done. Thank you. It was such an honor and a privilege to be on the podcast today.
To all our listeners, thank you for joining us. If you want to learn more about our work, please visit us at Aig-Imoukhuedefoundation.org or follow us on social media. Until next time, stay inspired, stay informed, and let's keep working to build systems that truly serve people.